Good evening, everybody. Welcome to the Suvarna series of events hosted by the Venugopal Association. My name is Rohini Rajiv. I am a committee member in the Managing Committee of MPA, and I'm also the chairperson of the Academic Public Services Publications Committee, under which the series of events come. I'm very pleased to see all of you this Saturday afternoon. May I request everyone to kindly go on mute unless you're a speaker yourself, please? Thank you so much. Really appreciate it. Welcome to today's very important event as we observe World Schizophrenia Day, which just passed yesterday. It was on the 24th of May. It is on every year. Today, Venugopal Association is observing World Schizophrenia Day through a panel discussion, and the topic is scaling a challenging frontier. We have some very eminent guests who are a part of our panel. Introductions will be in order once I hand it over to Dr. Ajit Bhide, but let's begin the program with a small invocation by our residents from the Venugopal Association. Over to you.
Bind us together, Lord, bind us together with cords that cannot be broken. Bind us together, Lord, bind us together, Lord, bind us together with love. There is only one God, there is only one King. There is only one body, that is why I sing. Bind us together, Lord, bind us together with cords that cannot be broken. Bind us together, Lord, bind us together, Lord, bind us together with love.
Thank you so much, team. May I request Dr. Joseph George, our president, to please welcome the gathering and also introduce Venugopal Association as well as the Suvarna series of events. Request you, Dr. George.
Thank you. Thank you, Rohini, for this time of given to me for welcoming the audience as well as the speakers for this afternoon. And I know World Mental Health Day is observed every year, and Venugopal Association also part of that observance, creating something or discussion about understanding the illness and caring for them. So all of us are aware that it is a serious mental disorder that needs a lot of empathic wisdom to understand the ill as well as to care for them. So I welcome each one of you for this panel discussion, including the eminent speakers that are with us, and they will be introduced and welcomed later. A few words about Venugopal Association. It's the first NGO, non-governmental institution in India, providing short-term and long-term residential care for the mentally ill and supporting their families. So over the last 5 decades, MBA stood for its excellence in providing residential care for those who are inside with us, as well as for supporting the family members, and series of mental health awareness program in the community at large, not only in Bangalore, Karnataka, but across India, helping with creating mental health awareness among the communities. So we are recognized for creating innovative residential care for the mentally ill, and we stood well in the last 5 decades in our service to the community. So MBI is recognized for the model that we have created and presented to the world, which is being followed in different sectors. And Dr. Joy Shiromani was the first founder secretary of this NGO, and started in 1964 and registered as an NGO in 1972. So the residential care, and then providing that kind of support for the families and regular programs that are aimed for promoting mental health happens to be the primary goal of MPA. This also includes managing a suicide prevention helpline with the name Sahai. So Sahai runs for 20 years completed, and this is again a suicide prevention helpline managed by NGO, by MPA and other similar organizations. Now, we have begun a series of lectures. So on celebrating Golden Jubilee 50 years after we completed 50 years of registration, we began a monthly lecture series on mental health, particularly with reference to the rehabilitation of the mentally ill. It started 2 years ago. So we completed 2 years now, and we are with the 25th lecture and 25th program. That means 2 years completed. We entering into the 3rd year. So the reception that we got with this series lectures happens to be extremely big. We are appreciated for this, and we continue. So after seeing the 1 year, response, the MBA management decided to continue. So we completed 2 years, and we are at the beginning of the 3rd year with the panel discussion on schizophrenia. All these programs that we have are available on YouTube. So you can get help from us in this. So it is my task to welcome all of you. Over to Rohini.
Thank you so much, sir. May I now request our moderator, Dr. Ajit Bhide, who is Emeritus Psychiatrist from St. Martha's Hospital, one of the most prominent figures in the field of mental health. Also, proud to call him the Vice President of the Venugopal Association. Over to you, sir, to introduce the speakers and start off the panel discussion.
Thank you, Rohini. It's an honor for me to be here today. So I was drafted onto this role a little late in the game, but here we are. So as you all know, the World Schizophrenia Day has been observed over the last couple of decades. And 24th May was chosen as the World Schizophrenia Day on account of its being the birth anniversary of a great liberator of people with mental illness, Dr. Philippe Pinel in France, who literally unshackled people who were brought to the asylums in chains. And he liberated people who were physically restrained because it was believed that people with mental illness were dangerous. The truth in that statement is very, 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 very tiny, and it was overrated. But Pinel's personality is commemorated in observance of this very important day. Today, to discuss what schizophrenia really entails, what people who have to go through it have to deal with, we have a very eminent panel. We have chosen a variety of experts so that we cover different aspects of this illness. We have among us a medical doctor with a background in psychosocial rehabilitation of people with mental illness. We have a family member, part of the famous FACEMi organization. By the way, nice to see you, Dr. Nirmala. And we have an actual counselor who works with us in MPA dealing with mental illness on a day-to-day basis. Allow me to introduce my 3 colleagues on the panel. Mrs. Susan Bhaktul is a single mother and a working professional. She has a background in textile and garment industry. She now works with an NGO that focuses on marginalized women from rural India. Susan is caregiver to her son Johan, who has a chronic mental illness. She has a daughter younger than Johan, Piara, who is married and well settled. Thank you for being here with us, Susan. We look forward to your participation and contribution to today's panel discussion. Then there's Ms. Agalya Venugopal, who did a master's in psychology and she now has 7 years experience in counseling and working with adult mental health, particularly chronic mental illness. She currently works as the Joint Senior Counselor at Medico-Pastoral Association. She also serves as a student orientation in charge for the past 6 years for the students at MPA. She also serves as a counselor at the Sahai, which Dr. Joseph George, our president, mentioned, on the suicide prevention helpline. Finally, but as the cliche goes, last but not the least, we have Professor Krishna Prasad. He did his MBBS from the Bangalore Medical College, and he's an alumnus not only of the Bangalore Medical College, but of the prestigious National Institute of Mental Health and Neurosciences. We asked him for his biodata. He's given a very, very brief biodata, so I'll just read out whatever he's had to say. Currently working as Professor of Psychiatry and Head of Psychiatric Rehab Services at NIMHANS. Welcome, Agalya and Professor Krishna Prasad. Can we avoid this, please? Rohini, can we have this?
So you don't want the spotlight on all the speakers?
No, not just now. Not
Okay,
just now.
all right. Okay, I'll remove.
Yeah, thanks. So that's a brief introduction to three people who constitute our panel. I'd like to say that just yesterday, I was told by Professor Srinivas Murthy just before we started our program, that there was another program by another very outstanding NGO, the RFS. And what came through to Dr. Srinivas Murthy, which he shared with us before the program started today, is that there is a crying need for people, for information, for solace, for knowing how to go about dealing with this illness. And that is a very well put statement, because I think there is a huge gap between our services available and the number of people required really to handle the situation that comes with chronic mental illness, particularly today our focus being schizophrenia. May I request my three panelists, one by one, to say something they'd like to, in addition to the little introduction that we garnered from them. May I start with you, Susan? Would you like to say something?
Yeah, I'm really glad to be here, and thanks Medical Pastoral Association for having me here. And beside this, what I wanted to say is that, the first thing when you realize that, that guilt feeling, that what did I do wrong? Why me? Why my child? So that one thing. And when Dr. Srinivas Murthy is talking about information, I wish I had that in the beginning. So that's a bit, yeah.
Okay. Agalya, would you like to say something briefly?
Firstly, thank you for, good afternoon all. Thank you for making me one of the panelists. So, as you all aware that MBA is the first mental health NGO non-government organization at Bangalore, credited with pioneering work in the field of rehabilitation of persons with mental illness. So our motto is to focus on the individual residents' holistic recovery and also on rehabilitation, re-socialization and resettlement. So I'll be continuing today's with the challenges that faced by the professionals at rehab centers. Thank you.
Dr. Krishna Prasad.
Thank you, sir, for the kind introduction. And I thank MPA for inviting me to this program. I think it's great to see a lot of family caregivers and maybe some users as well in the group. And I think it is important to understand that much of the decision making as far as treatment and management now has to be collaborative. And I think in this background, a lot of information and the correct information that needs to reach people, I think that is something that MPA is doing through this program. Thank you very much for inviting.
Thanks all three of you. And Susan, you started by saying that, why me? Does that question still linger with you? And if it has been addressed in some measure, have you got over it, or what? How do you deal with the situation where you
don't think, sorry.
Go ahead.
I don't think anybody totally gets out of, why me, why my child? Yeah, but then going forward, And when you meet people, like when I came, I mean, when I realized this, I thought I was all alone. And then when I heard of FACEMi, it's a Family Alliance on Mental Illness, and I became part of that group, it really helped me to understand that I was not alone in this journey. There were many people who were trying to cope, and there is a method of coping, and there's medical aid. You know, you go to the right place, you at the right time, and with the family support. Now I feel, you know, it's my responsibility. I don't feel it a burden. So that's the change that's come over me after a lot of time. You know, but anyway, I keep looking back and thinking that what could I have done better? You know, so I mean, I could have helped my child a little bit better. Yeah. So right now I'm in a situation where I'm coping, where Johan is absolutely coping superbly. I mean, we are like, you know, a fist, a family. So it's really helping. Yeah. But somewhere at the back of the mind, it is still there, you know, that, you know, so what is the next step? Yeah. And what after me? Who after me?
Right. Has any Mr. Prasad, has any work been done in this very important question of who after me? Because while the parents are there, most parents are very willing to rough it out, to go through the challenges that chronic mental illness brings with it. And their main fear is that if they are not there to support the person with the illness anymore, what's going to happen to them? What are the steps taken, and what are the facilities, resources available to address this very important issue that Susan has brought up to us? What after me?
I think we grapple with this question very often nowadays. I mean, with the going away of the joint families and largely nuclear families that we see, and we grapple this almost nearly every day in our interactions with the family and patients, that they really wonder as to who will be taking care of their ward after their demise. And it's a very difficult question to answer as well, because there are no one-size-fits-all kind of a response that we could give to people. We see people who are very capable of living independently. We do see people who recover significantly and are able to manage themselves independently. We do see people who have some challenges in some aspects of life and they require support. And then there is a third category of people where they are quite dependent for many activities of daily life, and they're quite symptomatic as well. So in such situations, they require a lot of support. And I think this is the category of families or patients that really bother us and concern. The kind of facilities that are available for such people is very far and few. It is restricted to some non-governmental organizations like yours and the RFS that provide long stay kind of facilities. But a large majority of our populace who come from middle or lower middle socioeconomic status, or even from the lower socioeconomic strata, do not have such facilities for long stay. I think that is one of the major concerns that that bothers us. I think the government is in the process of looking and addressing this, of course, with the help of the judiciary as well. But I think it is it's a long way that we have to go to deal with the long stay facilities. But even before that, I think we need to create spaces to support people who require some degree of support. There are options of, say, the families forming trusts. There are options of families looking at willing their properties. To an extent, limited guardianship might be something that the families may consider. So there are a variety of options that are there and a variety of avenues that are there. I think strong family caregiver and user-based advocacy probably would hasten the process of the government also looking at this as a priority.
Right. So we don't have a firm policy in place just now. We rely still a lot on family resources, and that's the way it's going to be for quite some time to come. In certain countries, especially where the welfare state is there, these questions are considerably mitigated by the state taking over and addressing these issues. We're a long way from there, but hopefully some steps will be taken in that direction. I remember the Medical Pastoral Association itself. I was not involved in this particular venture, but they came up with the help of a lawyer, with our head counselor at that time, Mrs. Lata Jacob, who was subsequently a president. They came up with a booklet that was that received some prizes, some awards. It was called "What After Me," and that "What After Me" also did not really answer that question, but threw up a number of options. And I think we need an update on that as we go along. Agalya, you've been dealing with people with chronic mental illness. I'm sure a few cases come to your mind where the diagnosis has been schizophrenia. Would you care to share with us what are the challenges that individuals with this illness face, and then also with the kind of challenges that you as a counselor have had to face dealing with this, the patient's behavior and the challenges they face?
Yes, sir. Before I go with that, I would like to also share that, in fact, our residents' family members also, they raised this consent of what after me. And now it is like who will be taking care after me of my ward. That is also the concern. In fact, yesterday we had a family meeting. Many of the residents' family members are getting old. So few residents' family also, they are looking for the next primary caregiver. So we have asked them to look into the next primary caregiver and to share their details. So since the current primary caregivers are becoming old, so that is also we are on the process to make sure that residents are taken care by the next caregiver. So
That's nice.
with that thing, I would like to share the difficulty or the challenges that we face here. So there are certain residents who have this non-compliance to medication. We find it challenging when residents constantly have complaints towards medication and its side effects. So certain residents will come and share that I find difficult with this medication. The tremors are increasing and it is very difficult for me to run with my day-to-day activities, all those things. So when that is shared, we inform the family members to take the residents for the doctor's consultation. But certain times family denies to take them because recently they would have gone for the consultation and doctor says that no, it will take some period of time to react with them. So when it is shared to them, the residents also will feel that no, I have to be shown to the doctor immediately. There should be some change. So there are some difficulty to make them understand. But the family also expect that counselor has to give them counseling on taking medication aspects. Like this medicine is for this purpose, you have to take it. So they expect us to counsel on taking medications. So these are the things that I noticed recently when few residents having this non-compliance to medication. And quite a residents have this complaints and they try to skip out the medications. So it is not regularly. They know that this particular medicines give me this kind of side effects, so I don't want to take it. So they skip out the medications. So those things also we have noticed. And certain times we keep the doctor informed and we follow up with the family and we ask them to take for the consultations.
Now, quite apart from the medication, what are the challenges you face apart from medication? Non-compliance with medication is definitely a major issue.
Yes, yes.
Parents' reluctance to go for an emergency consultation might, or from what I gather from you, also be an issue. But quite apart from that,
there are residents, few have that reluctant to attend the activity. Some are due to amotivation and medicine side effects, psychosomatic symptoms.
Leave the medicines and the side effects completely
Yes.
out of this picture now. You've spoken
Yes.
quite a bit about it, and that's important, no doubt about that.
Yes.
But beyond medication, what are the challenges that are faced?
So sometimes there are residents like they have poor personal hygiene. So when it comes to poor personal hygiene, we have keep on monitoring them and we tell them to focus on that. Even after telling many times, they fail to do that because having this chronic illness for a 2 weeks period, they follow that. After some time, they come back to the same issues. So they have that difficulty to follow. So constant instruction has to be given. And since they have this negative symptoms of social withdrawal and sometimes lack of motivation, difficulty in daily activities, all those things leads them to not to focus on the things. So we keep counseling them and we tell them. So all this thing makes complicated. And also some residents have this inappropriate behavior. We have also experienced certain residents like verbal abuse or physical abuse toward co-residents and sometimes staff also. They become violent and losing the control and breaking the things at the facility. So we have come across this kind of experience also. So when that is happening, we keep the consulting the doctor informed. If the SOS is there, we give them. If there is no SOS, then we have to inform the family and the doctor for the next process of dealing the client. And also, yes, sir.
Yeah, go ahead.
Yeah, and also there are transparency in communication. Certain times, the clients feel that family is not kept them certain information not clear, like fear of long stay. They would have completed. See, our RFM process is 6 to 1 year period. Means certain residents are there here more than 2 years, 3 years, but they have a fear that how long I should be here in the facility. Why my family is not taking me for the discharge. So, but when we check with the family feels that the client is not still settled down. Let them take some more time to be in rehabilitation process. There are areas need to be improved like that. But the family is not openly sharing with the residents. They share or discuss with us, but we try to make a platform for family session to keep them informed that, yes, these are the things that family expecting. And if the progress is happening in on that area, family will be taking them for the discharge process like that. So there are few transparency in communication with the family and the residents understanding is quite challenging. And also difficult to work with people who doesn't have the insight. So to educate them about the illness, all this like it is complicated for us.
Right. Before I move on, can I request anybody who has any questions to ask regarding particularly schizophrenia, please put it in the chat box. We will definitely address all your questions. If you have any comments about what is being said over here, we'd be glad to hear those as well. So please feel free to put in your questions starting from right now. We will take up all the questions and comments right at the end, but we encourage you to participate. If possible, we may even ask you to ask the question that you have put up in the chat box yourself. But coming to these, the issues that Agalya seemed to focus largely on was with regard to medication. Now, schizophrenia broadly has two sets of symptoms. This segregation is slightly artificial, but it's quite useful that you have positive symptoms and you have negative symptoms. Positive symptoms are actually manifest disturbances such as hallucinations, delusions, or very odd motor behaviors. And negative symptoms are withdrawal of normal behavior, and the patient becomes apathetic. He seems not to have any expression. He seems to be in a withdrawn sort of state. And when I was just finishing my post-graduation, this bifurcation into positive and negative symptoms was very much in fashion. I think Professor Timothy Crow from the UK was the first one to enunciate this. And the exciting thing that happened in the next few years is that a large number of drugs started coming in that address the issue of negative symptoms. We've had a slew of newer and newer medications over the last 3.5 decades. But how much of a difference has this made to the actual outcome of this illness? Dr. Krishna Prasad, I wonder whether you'd like to take this up and tell us something more about this. Over the years, schizophrenia has had a tendency to a feeling of doom that comes with the diagnosis of schizophrenia. How much has that changed now over the years with newer and newer medications emerging on the scene?
Sir, I think, as you mentioned, this division of symptoms into positive and negative symptoms probably still holds sway and relevance as of today. And I think it's also important to understand that with advancement of the psychotropic, and particularly the antipsychotics, there is a lesser degree of the traditional side effects that you had with the use of the first generation antipsychotics. Now we are talking about third generation antipsychotics. Also importantly, the advent of clozapine probably brought about drastic change in the outlook for patients who were supposed to have resistance to 2 or 3 antipsychotics before they were prescribed clozapine. Now, though the atypical antipsychotics or the second generation antipsychotics were touted to have lesser degree of extrapyramidal side effects and probably a greater degree of effect on negative symptoms, to which probably the first generation antipsychotics were not really effective. But over a period of time and also experientially, we don't find that they significantly change the negative symptoms or the cognitive deficits that are associated with the schizophrenia. So to an extent, they may be helpful, but probably to make practical differences in the lives of people, we do see challenges even with the use of second generation and third generation antipsychotics. So I think it really emphasizes the importance of non-pharmacological interventions and also the fact that other aspects of providing care for people with severe mental illness like schizophrenia, like say opportunities for daycare, opportunities to learn skills in a halfway home, and these kind of therapeutic environments probably provide opportunities to assist people with negative symptoms. Also, I think in terms of other interventions, probably interventions that address social skills issues and to an extent remediate cognitive deficits. I think these are things that shouldn't be underemphasized as a part of a standard of care for people with schizophrenia.
Very correct, and I'm glad you brought up the emphasis on cognitive symptoms in schizophrenia, because we tend to think of schizophrenia as characterized mainly by hallucinations and delusions, and the focus for a long time was only on those. Actually, when Kraepelin first identified this condition, he called it dementia precoce. That means dementia that comes before its time, clearly emphasizing the fact that the mental functions are deteriorating, somewhat like dementia. But then Eugene Bleuler, to whom we give a lot of credit, said that cognitive decline is not a characteristic of this condition. He coined the term schizophrenia just over a century and a decade ago. And he also clearly said, and this came into vogue more recently, that it's not schizophrenia, it's not a single condition. They are schizophrenias. There are certain uniting factors, and still there are a number of other features that distinguish one type of schizophrenia from another, to another. Of course, the typology that existed at his time has undergone a sea change, but each of those conditions imposes a certain burden, not only on the patient, but also on the family. Susan, as somebody who's been dealing with somebody with a chronic mental illness, I'd like it, if it's all right by you, for you to share your personal experience in this problems, the quandary that diagnosis is. And I understand from you that your son's illness was diagnosed in different ways at different times. Also a personal touch of how you coped with all that is gone through, all that you've had to go through on account of your son's illness. I was glad to hear from you at the start that he's doing quite well currently. But could you share your journey on this, particularly focusing on the diagnostic conundrum with us?
Yeah, when I first realized, I mean, I didn't know it was a mental illness. He was using drugs, so I took him to St. John's for that, because he was heavily into drugs. So we took him to St. John's, and that is where he was diagnosed with schizophrenia. And then when they started...
How long was it from the, sorry to interrupt, how long was it from the time you first said there was something odd about him to the time the diagnosis was made?
He was around 21, and I'm separated, so he was staying with his dad, and I didn't realize that he was on drugs. Then when we realized, and I took him because Dr. Chitranjan Andrade of NIMHANS, he's a family friend, and he suggested, immediately admit him into St. John. He was there for about 4 months, absolutely. He was, when we put him there, he was abusive towards me, towards the doctors, everything. And then the doctors told me, don't take it personally, because this is not Johan who's talking. So I think after 3 months or so, after he had calmed down and they had given him some medicines and things like that, then they did some tests and they said that he's got this illness. And of course, we were all in denial. You know, I was like, no, it cannot happen. What is this? He's only on drugs, so just get him out of it. Things like that. And after that, he came out, and then I mean, he's not completed his education, because every time he went in for engineering, he went in to do music. He, I mean, tried doing his degree. He could not finish anything. And most of the time, what happens in a family, if you're in denial, you keep thinking that, you know, I mean, he's not brought up well. You know, everybody says that, you know, he's been not brought up well. You guys did something wrong when he was a child. All that just plays in your mind. You know, I remember telling the doctors also that, you know, no way can he have a mental illness. It is not possible. So that was the thing. And then, you know, slowly we realized that, you know, instead of getting into this pity scene, you know, instead of getting guilty, feeling guilty every moment, listen to what the doctors are telling you. You know, listen to them, because there's a lot science has come forth. I mean, like listening to you itself, you know, from shock therapy to now, there's so much of medication, things like that. So the journey with him, with Johan, was, you know, and I'm a working professional, I'm a single mother. So it was not easy. It was just very difficult. I think somebody is speaking.
Dr. Bon Isaac, can
Yeah.
you? Sorry.
Yeah. So
Thank
I
you,
mean, the thing is that, you know, that when then it was that he did not have insight, of course, in the beginning, right? He did not have insight. He would tell me that, you know, you'd blame me for everything, you'd blame his dad for everything, all that was going on. Then when he started taking medicines, we left him on his own, thinking he's taking medicines, but he didn't take medicines, so he would get withdrawals. So the last episode he had, I was not in Bangalore, I was living outside of Bangalore. And when we realized he was in a very bad shape, really bad shape. And then I was advised that, you know, you need to put him in an institution, or he has to have a home atmosphere. So I took him with me, because he was not staying with me. So I took him, and I put him in an institute for some time. But, you know, after a very strict monitoring, and I feel that, you know, that I do not feel, if I take it as a burden, if I take it as a, you know, like, what is this, you know, happening to me? After I've gotten out of that zone, now when I say that he is my son and I am the mother, this relationship I have to build. You know, he is my responsibility. And when I start enjoying whatever he's going through, you know, I support him completely on that. It makes the journey very much better, you know. And once he started taking his medication from, you know, I think what his last episode was some 4 years ago, 4 or 5 years ago. After that, he's very careful with his medication. He almost remembers the hallucination, you know, he remembers the voices in his head. He remembers how terrified he was of simple thing of somebody wearing a certain color. You know, he was terrified of my maid's husband, who would just come there, and he's like, no, he's going to attack me, he's going to kill me. He remembers all that.
He
So
remembers
now-
and realizes that that's not real. Does he have insight into the fact that these fears were unfounded?
Yes, now he has an insight. Now he has the insight of these things, but still that little bit is there, you know, that grandiosity is still there, that I can do anything, you know, things like that. And I'm very grateful to, you know, to Dr. Nirmala for, you know, all the group meetings that we have, all the feelings that we can share. And I also am very glad that I have friend circles who are very helpful. Johan is now working with a friend of mine in a restaurant, because I think that helps, you know, that when he goes out of the house for about 4 or 5 hours, meets with strangers, talks with strangers, that really helps this person. So Johan has really improved because of that.
So the confidence and the self-esteem both get a boost when the kind of exposure that you're talking about is there. Of course, it's useful to have some very caring, benign person to guide the sufferer of the illness. But there were 2 questions that I asked you. Your journey was very useful and interesting for people who have are co-sufferers of this kind of condition as caregivers. But I wanted to know how long from the time there was a need for treatment to reaching the treatment actually. How long was that gap? And secondly, what I understood from you in our private talk was that the diagnosis kept changing. And how much did it
Yes.
throw you, the caretakers, off?
See, when he was in school, I think, he was never interested in studying as such. He was very intelligent because at the age of 4, he could read. Then I realized intelligence has nothing to do with mental illness. So, we all thought, with this intelligence, why is he not studying? So I think it started, if we had, again, it's that regret thing that if only I had noticed it when he was younger, because all these symptoms were there, that he was not concentrating, he was not mixing, he was very angry, he had this grandiosity, things like that. Then at the age of 15, 16, he got into drugs. And, after that, when I realized that he was heavily into drugs, and we took him to St. John's and we admitted him. After that, the diagnosis was quite fast. Now it's about 2-3 months, and they told me that, we think he has schizophrenia. Yeah. So, but when it started, I'm sure as a young boy, which we did not realize, and we just kept putting it off, thinking that again it's the same thing, that, he's not well behaved, he's not, those kind of things which come in. Yeah. So that was what it was. And when they diagnosed as schizophrenia, then they started giving him medication, but later they said it was schizoaffective. It was not schizophrenia. And after a while, the doctor said that, no, it's bipolar. So, it's just been fluctuating, and I am not an expert in this, so I depend a lot on the doctors, what they say, and I watch for his behavior. So there has been a shift of diagnosis, yeah, from what he was and what they tell us.
You're not an expert, you say, at one level. At one level, you're much more the expert than many of us. When you live the life and when you are the caregiver, there's so much we can learn from you, because the practical problems are always there. And this bit about intelligence you mentioned, it spares nobody. The most famous example, of course, is John Nash, the Nobel laureate, who actually had a schizophrenic illness going on for quite a significant part of his life. Many of you may have seen the movie. But what was most interesting to me, and this comes to what Agalya was talking about non-compliance with medication, that suddenly the medication seems not to be working. And then his wife, who was an excellent caregiver, notices that all the medication has been taken into the mouth, spirited away, put away in a drawer. And there's a drawer full of about 300 tablets over there, very neatly brought out in the movie and also in the book, that John Nash had not been taking his medication, and his hallucinations had become very, very florid at that stage. Agalya, sorry. What is your experience with parents sometimes, or family members who are caregivers, not necessarily parents, who are also in denial, who don't want to admit that there is a serious illness going on that needs care? Because you are given a patient and say that please arrange for his counseling. Sometimes you're the counselor yourself, sometimes you have to allocate a counselor who's junior to you and whom you supervise. How often is there a denial of the process among parents in your experience?
Yes, sir. There are parents who are not understanding that the residents having those difficulties. Certain times, I can give an example that recently one information came for the admission, where the family came with a person saying that he is withdrawing from his college, he is not continuing his studies, he's showing some uninterest towards studies like that. Then one of the doctor advised him to be in the rehab process, to go under this process like that. But when the family came here for the information, they went through the information, they collected application form, everything. But in the final, they are saying that this age group of people will be finding difficult. So we don't want to keep person here because he might get looking at other residents' symptoms and behavior. He will adopt that behavior. So we wanted not to admit him here like that. Those confusion stages are there with the family. They are not clear how the residents will be held. But we do have a resident who's going to the college regularly, being with in the campus, doing our therapeutical activity, attending all those things. The residents goes for the college and he returns back to the MPA. and he does his routine as per the schedule, whatever we give the timing for him. So all those things are there. But in certain areas, family fails to understand that the insight level of the residents, what they have, or this is the chronic stage of the illness, but even after they getting better or the thing, they expect more and more. So still my ward has to be improved in those areas. Still they are not settled down. So what is the condition? When we look into that pre-morbid personality also, it is not that previously the person was extrovert or some kind of thing. So when we compare that, the person is to be having the same things, but family is still having difficulty to understand these are the level that they can improve like that.
Right. So does it happen very often? My early days with MPA, that the primary caregiver is usually very cognizant of the fact that help is needed, that there is a illness. But there are other people on the scene who undermine the process. They mean well, but the path to hell, they say, is paved with good intentions. They mean well, but they say, no, he needs more discipline. Just pull up your socks and move on. That kind of philosophy that kind of approach seems to dominate very often. And then the medical management is given a backseat, if at all. And that undermines the whole process. Does that happen in your experience?
Yes, sir. Yes.
Okay.
There are a few residents also having that unwillingness to be part in the activity. And sometimes if the residents are new to the facility, they won't show interest to get for the therapeutical activities or the program that we conduct. But we keep them motivated by giving some reward system of token economy system. So that motivates them to be part in that. But slowly they will take time to accomplish with the activities and the program that we have. But family will expect after they get admitted with the resident within 3 months, or they will ask within a week also they will ask what is the improvement that my ward is having, any changes are there. So the expectation they will ask whether it is fast or like that.
So can you tell us a little more about this token economy and how you practice it in MPA?
Yes, we have a set of therapeutical activity. So day-to-day functioning, whatever the activity that we have, right from 6:30 to till the evening.
Could you enumerate some of those activities that are there?
Yes,
Therapeutic
we have
activities.
a therapeutical activity like group therapy, art therapy, then drama therapy, social skill training, life skill training. So these are the therapeutical activity which involves also poetry class for the resident. One of the residents take the poetry class for the other fellow residents, and cookery class will be done, indoor games and outdoor games.
Right.
Whatever the residents they do. So when they get up in the morning, once they finish with their personal hygiene, they will be coming with the maintenance. So maintenance also they will be dividing. One will be going for kitchen cleaning, like kitchen cutting the vegetables, and one will be going for gardening. One will be going for room cleaning. So whatever the activity they take, they will get a points and it will be rewarded for them. So it will be converted to the token economy system. So once they earn the point for the month, whatever they have done for the task for the week, so the responsibility that they take and they involve in the process, they will be getting a reward. So with that reward, they have a chance to go for movie out or lunch out. So it is in a alternative month, we take them lunch out or movie out. So with this reward and this thing, it makes them motivated to be part in the therapeutical activity. But still certain residents have this complaint of side effects of medicine. I am finding difficult. There are residents who have complained towards psychosomatic symptoms, but still we keep them motivated with this all reward system. But there are other residents, fellow residents also motivate them. Hey, come on, I am doing good. I am also taking medication. You come with me for the program. So let's join through that. So individually they talk to them and they mingle and they motivate each others. So that is also we have seen with the system.
So with desired behavior, points are earned with a cumulative number of points. The rewards are given to the individual. It's interesting because when token economy was first introduced, the reward used to be cigarettes, because it's well known that patients with schizophrenia are much more likely to find pleasure in smoking, and that there is a pharmacological reason for it also, because nicotine does have a certain calming effect on many of these individuals. It has a very limited stimulating effect also, but cigarettes were a bad idea, especially from the physical health point of view. It was a bad idea. But what's our approach to smoking in a center like MPA?
Earlier, before the COVID, we had a residents who have chain smokers like that. But later period of we had a smoking sessions where all staffs together came and we discussed with the family members. We slowly started giving them rationing the cigarette. So per day, if they attend the activity, they will be getting 1 cigarette like that. So in the initial period, we used to give that rationing of cigarette. So per day 4 like that, whatever the activity they attend, we mark the attendance and we used to give in the middle. But after this COVID effect, the residents who got affected from the COVID, they got admitted to the Victoria or other hospitals. So during that period, they also got to know the complications of smoking and things. And now nobody is smoking at our place. So it's smoking free zone area.
Excellent. I hope that is maintained. It's very, very important now.
And as
yeah.
I mentioned, this therapeutical activity, we have reward functioning. The same way, we also have like certain residents have, they don't take personalizations regularly. Certain, they are ignoring with that. So sometimes we make them motivated. If they come for breakfast, they have to finish with the personalization, then they have to come. So we won't deny the food. We will be delaying the food so that they will make sure that my friend is taken breakfast on time. Why my food is delayed like that. So that delaying makes them understand and motivate them to take personal hygiene and come for the activity or the program for the day-to-day things.
That sounds like a somewhat ideal setup where people accept these explanations, but I'm sure sometimes it's challenging and they say that this is not on and it's just unfair. Anyway,
Yes.
this conundrum of diagnosis that you referred to, Susan, I'd like Dr. Krishna Prasad to take this up, because the steadfastness of the diagnosis, whether it's schizophrenia, schizoaffective, or affective disorders, right from the time I was a postgraduate student, I noticed that there is transition from one diagnosis to another. Where do we stand with this, Dr. Krishna? Because I learned that in genetic studies, it seems there's a huge overlap between the genes responsible for bipolar disorder, schizoaffective disorder, and schizophrenia. There is a huge overlap of sorts. And clinically, it's very easy for us to say that bipolar is a well-defined illness, schizophrenia is a less well-defined illness, but I'd like your wisdom on that, Dr. Krishna Prasad.
So I think taking a very categorical approach, most of our current classificatory systems meant for diagnosis take a very categorical approach. Of course, now there is a mix of categorical and dimensional approaches. Clinically also we observe, and also as you said, literature also now supports there is a lot of diagnostic flux. So you do see patients who may, as Susan mentioned, that in the beginning diagnosed with schizophrenia and subsequently there is a fluidity and a flux towards, say, bipolar disorder. So we also see category in between that, the schizoaffective disorder. So as you already mentioned, I think it is now known from genetic studies that a lot of risk factors are common across many of these disorders. The genes that are involved, all of them probably polygenic with small effects. So they are all quite common across these broad category of severe or serious mental disorders. So I think it's very difficult at times to convincingly say that the diagnosis will stand as it is, say 10 years down the line. So I think as symptoms evolve and as the changes happen, I think both the prescriber as well as the family and the person concerned will have to deal with it as and when it comes.
So the transition from one diagnosis to another still does happen, but especially with the I think the ICD, the latest edition, there is a concept of dimensionality which is taken into consideration, saying that on certain dimensions it looks like illness A, certain dimensions looks like illness B. But I think we are back to actually just having a broad category of psychosis with defining which are the well-defined symptoms that are given in a particular case. And the overlap between bipolar and schizophrenia is there. In a few cases, it's very sharply different, but in many cases, the overlap remains. Am I right in saying that?
Yes, sir. I think you're right in saying that. And this category of schizoaffective disorder probably exemplifies that.
Right. I will go back to what Susan had said earlier about, the social milieu tends to blame the parents and bad parenting and the atmosphere at home being responsible for bringing about a psychotic breakdown and perpetuating psychiatric illness. I remember when the psychoanalytical school had almost a stranglehold on the practice of psychiatry. It was there were expressions like a schizophrenic mother, that a particular type of Dr. Mohan Isaac used this term in a different context a few sessions ago, that you have a refrigerator mother, very cold and indifferent type of mother who brings about a certain unwarranted behavior in the offspring. And there was schism and skew in the parental relationship. We have moved a long way from there to realizing that parents are a poor cause of schizophrenia directly in terms of the interactions. But in terms of the genes they contribute, which is not really up to them what genes they can and cannot transmit, there is a genetic element that dominates in people who will eventually have a schizophrenic or major psychotic breakdown. Any information for us, especially for lay people who are interested in mental health as well as caregivers, Dr. Krishna Prasad?
I think family plays a very important role in providing care to people with severe mental illness, be it schizophrenia or bipolar disorder, any other form of psychosis. I think we moved from the stage of attributing causality to the family to involving family in the care of people with mental illness. I think what is well established is the role of family in terms of providing warmth, in providing unconditional support, and a degree of independence to the person with mental illness to improve outcomes. What probably worsens outcomes are being very critical of the individual concerned, or being extremely over-involved, or being hostile towards the to the person affected with mental illness. I think this is pretty clear. So family in our context has a significant role, and probably several studies beginning with the landmark WHO studies have said that the outcome probably in so-called low income and developing countries is probably better because the families are involved in the care.
Right. So those range of emotions that you mentioned, expressed emotions, those are the ones that are really an aggravating factor rather than a causative factor. Am I right?
Yes.
Okay. From here, if there are any questions, anybody who would like to raise their hands, we'd be happy to take on questions. But I want to say that the schizophrenic mother does not exist. There are personality issues that can come because of bad parenting, but not really major psychiatric illness, major psychiatric breakdown that comes on account of any faulty parenting. I notice that we have few items in the chat box. I'll just go through them quickly. Mr. Guest, will you first identify yourself, because we don't know your name at all. You have a facility for naming yourself, after which I'll invite you to ask your question. Sydney, you said drugs as in, I know drugs is a very confusing term by itself, because we use it in a pejorative sense for chemicals that are badly, that affect a person's psyche and behavior badly. And we use drugs also for the pharmacological treatments that we use. What exactly was your question, Sydney? Please unmute yourself and ask the question. Sid, if you're there. I think Dr. Nirmala asked this question. Has there been any diagnosis that is an overlap between psychosis and neurosis? Krishna Prasad, would you like to take that?
Yeah, I think we had earlier categories of schizophrenia, which included pseudoneurotic schizophrenia. But of course, now there is a significant bit of understanding that many of the chronic illnesses share common risk factors and common predisposing factors, now including many physical illnesses. So there is this concept of multimorbidity, where there are more than one co-occurring disorders that we see, particularly chronic disorders. So it's not limited only to mental disorders, but also to mental and physical disorders. So there is this problem of, I mean, we need to deal with this dichotomy of mental and physical disorders, and also this dichotomy of psychosis and neurosis. We do recognize that the current classificatory systems also lay emphasis on the fact that anxiety may be an important symptom that is seen in people with schizophrenia. Depressive symptoms may be an important symptom that is seen in people with schizophrenia. So there is overlap, and that strict delineation that you would expect, demarcation that you would expect for a clear-cut psychosis to have only so-called psychotic symptoms and people to be immune probably doesn't really exist.
So we would also be correct in saying that neurotic symptoms can indeed occur among people who have a psychotic breakdown.
Yes.
It doesn't have to be pseudo-neurotic really, but for example, anxiety is a common attendant on many people with both positive symptoms of schizophrenia and to a lesser extent in negative symptoms of schizophrenia, right?
Yeah.
Depression is definitely an accompaniment in a substantial number of cases of psychosis. And so neurotic symptoms can occur. So there can be an overlap, but it is not a, please correct me if I'm wrong, Krishna Prasad, it is not an indicator of a very well-defined etiology that we are really talking about when we have neurotic symptoms in people with psychotic breakdown.
True, sir. And also, I think there are other aspects of so-called neurotic symptoms. I mean, there are these issues that surround demoralization that happens to people, particularly those who are high functioning, about the change in their status following the illness. I think whether you consider that as a neurotic symptom or whether it is a degree of helplessness and hopelessness that they develop subsequent to the diagnosis of the severe mental illness, I think all of that also has to be considered.
Okay. I'll go to the raised hand over there. Mr. Guest or Mrs. Guest or Miss Guest, could you please identify yourself? Please unmute yourself. Please let us see you and introduce yourself because we don't know your name at all.
You see, I am taking medicine for last 40 years for schizophrenia.
May I know your name, sir? May I know your name?
My name is Bajrang Lal, and
Yes,
I am
Mr.
taking
Lal.
medicine for schizophrenia for last 40 years. And I have not taken any counseling till now. And should I take counseling or no? It is not needed because I am living in with my family, and sometimes it is little bit irritation, but otherwise it is good.
Where are you, sir? Which city or town?
Mumbai.
Acha. Have you discussed this issue with your doctor? Whether you should go in for counseling?
I am going to the doctor and he has prescribed the medicine Serenase 5 mg and Arpidon 1 mg.
No. Your specific question was about counseling. I want to know, have you asked your doctor whether you need counseling and whether it would help?
No, I have not asked doctor that I need counseling or not.
I think it's a good idea that when you have your next consultation to bring this up. I feel that a certain amount of psychotherapeutic support is very useful in most cases. It's not a story of medication alone, though there is no gainsaying the fact that medicine is the most important part of your treatment. But counseling may help you to cope with life much better. I'm using over here counseling interchangeably with psychotherapy, and I think it's a good idea for you to bring this up with your doctor. If you cannot resolve this with your doctor, we will give you our mail address. Rohini, can we arrange for that?
Yeah.
You can get in touch with us on the mail, and we will definitely help you address this question. Okay?
Please.
Okay. Thank you. Thank you, Mr. Lal.
Thank you.
Rohini, you yourself have raised your hand.
Yes, sir. I had two questions. One is a common question or a query that comes with a lot of, I have a mental health organization myself, and we work in the proactive and preventive mental health space. We do have a lot of clients who come in with psychosis and families who come in fact, for their support more than the actual client with the psychotic symptom. What they ask, especially youngsters, when they have a parent diagnosed with schizophrenia, is worry for their child. So they want to know what is a genetic predisposition? Will this happen to my child? Can we stay together? My in-laws or my parents with schizophrenia live with us. My children are seeing the symptoms. It's a bit scary for them. I'm trying to protect them from there. Should we live separately? Is it contagious? Will this happen? Will it be learned behavior? That's the first question I had. Some sort of inputs there. Secondly, I also wanted to find out what are the protective factors that we can talk about in terms of, again, coming back to children. or youngsters? Is there anything like protective factors here? So these are the two questions I had.
What you spoke about, some symptom contagion, I think Agalya in her last few remarks had also referred to it. We are very scared to keep the patient over here because he may pick up other symptoms that other residents at your center have. Yeah. Krishna, would you like to take that up?
I think
sorry, the burden is on you as the medical specialist among us to address a lot of these treatment-based issues.
I think there is a lot of heritability that is there as far as many serious mental illnesses are concerned. So at least with schizophrenia, the heritability is approximately around 80%. So there is a strong factor of heritability that is there. But it is not a specific gene that is involved. So it's not very easy to predict that way. So it's also related to the question, I think, which Sumit has asked on the chat as well. So there is no single gene that has been implicated. But it's well known that even with the, say, twins who are identical, there is a 50% chance that if one of the twins develops schizophrenia, the other twin is likely to develop. So similarly, if there is one family member who is, say, a first degree relative, somewhere between 1 in 10 to 1 in to 1 in 5, there is a chance that you may develop schizophrenia. So there is a strong genetic component that is involved. So it's not a single gene that's involved. Very similar to what happens with other chronic illnesses like, say, diabetes and hypertension. It's also modulated by the environment to a large extent. So to an extent, a protective environment can kind of mitigate the genetic risks. Not everybody develops schizophrenia in the family. So it could be inherent resilience, which is there in the individual, inherent genetic factors that are there in the individual, lack of exposure to substances like, say, cannabis. So social adversities. So these could be protective in that sense.
Does that answer your question, Rohini?
Thank you, Dr. Krishna. Yes, it does. But I would also appreciate inputs from you, and because it's just something I'm sure you've seen this as well in these questions.
I think for children, it's a very important facet that you brought up about children. And I think the important thing is to have wise elders around to explain that this is normal behavior. This would not fall into normal behavior. And normality is very difficult to strictly define. But one can make out that something is acceptable, something is not acceptable. And children must be given that guidance. Children must be told not to imitate any psychotic behavior that an elder with the breakdown has. At the same time, we need to have this person integrated into the family, which becomes something of a tightrope walk. But that tightrope walk has to be walked. There's no running away from that particular situation. I'm particularly concerned with children's mental health. And in that context, this is what I would have to offer.
Thank you.
Ms. Sumit Guha, is your question sufficiently addressed? If not, would you like to say something more? Because I noticed Krishna Prasad did attempt to answer that question. To go back to basics, how we know that something might have a genetic basis is if two people have similar genes, but they are in different atmosphere, different environments, and in one has a breakdown and the other doesn't have the breakdown, the chances are environmental factors are more important. If both of them have the breakdown, if they have similar genes, then the chances are it's a genetic breakdown. The other thing is twin cohort studies, which Dr. Krishna Prasad addressed. If two people are identical twins, which is a rarity, of course, but that genetic pool is totally identical twins only. If both of them have the illness, then the concordance, as we call it, speaks for how much is the role of genes in the breakdown of this process. And the Scandinavian countries were the ones who gave us very good data in this more than 60 years ago. And from there, we have concluded that genetic factors do play a role. Also in the Scandinavian countries, there's a meticulous record keeping of people who are given an adoption. So you look at the adoptive relatives and you look at the genetic relatives, and if there is a greater tendency for the illness to occur in the genetic relatives, the chances are this has a genetic basis. It doesn't mean genes are the be-all and end-all of the story. Far from it. Dr. Nirmala has a question and also a suggestion. Nirmala, could you unmask yourself, please? Dr. Nirmala?
Yes, unmute. Yeah.
Hi, good to see you here. You've always been a great patron of our activities. Thank you.
I love to. I really benefit a lot. And the sense of camaraderie that we belong to something is a great thing, Ajit. Like Susan said, you know, it's a very great thing. We are not meeting you, we are not being there, but still the fact that we are connected is enough. That's most important. So it's like this, my observation. And it's also to some extent my personal experience. The first diagnosis, I'm going back to Susan's experiences, the denial, the guilt feeling and other things. So the first diagnosis, we go to some doctor after maybe the gap, the minimum gap I have found in based on my two decades thing with the families is 2 to 3 years. They don't go to seek psychiatrists. They might have seen other doctors, but not the psychiatrist. Somebody even went to a gastroenterologist because somebody was told that the stomach is the second brain of the body or something like that. So they thought he should go to that's on the maybe a comic error, the comedy of errors rather, but that's how it is. With no offense meant to psychiatrists, I would earnestly request the psychiatrists, they have a lot of compassion and sensitivity, no doubt on that, for the families. At least I have come across psychiatrists who really feel for it. But when you communicate the diagnosis the first time, please understand it is like a death sentence pronounced. It should be as, you know, like saying for a little child, you know, pink ribbons and ice creams and soft touch. Make it as less as harsh as possible. Of course, you are a doctor. You have your ethical obligations to communicate. Definitely, you are not going to hide. We don't want you to hide and so on. But when you say, like I was told, I'm sorry, I hope I'm not being, I hope it will benefit all of you. With no offense went to the doctors there, please don't. I was told your son won't be, that time my husband was also there, fortunately I had somebody to share. So I was told, your son won't be able to do anything in future. So try to think he won't continue his engineering. He won't be able to, maybe you can find him a shop where you can sit him, make him do some business. I mean, this is not required in the first thing. Number one, not being able to do anything. I'm just giving a food for thought for all of us. Is there any other way of communicating the diagnosis for the first time or the second time, first two diagnoses, slowly peel the onion layers, slowly take the parents or the families, or the carers along with them. That is one thing. I don't know whether I put it across clearly. Don't make it a clinical experience. A psychiatrist, for a psychiatrist, it's a different thing. A clinical experience for a psychiatrist is different to a clinical consultation or a clinical interaction, whatever, transaction, whatever you call it. For a surgeon or for a cardiologist or for a pulmonologist, it's different. For anybody, you should give that soft touch. But in case of a psychiatrist, it's even more, because it's got other ramifications beyond you, beyond your clinic. We enter into a family. As we get out of the car and get into the family, the fight starts. Unless few hours back, a happy, harmonious family. You did this, I told you long back, don't put him in this college. You put him in the hospital and therefore it happened. You get what I'm trying to say, Ajit?
I think so.
That is very important. So
I remember you and I having talked about this also way back when Wing Commander was there.
Probably, because it hurt me very badly. I mean, you also won't know. whether the boy can do it or not. The doctor only knows the medicines and the biochemicals that is required. How it's going to unfold, how is
In the
this?
family.
Yeah, but why say it? Because the person who said it must have said it with a lot of concern and care, looking at our faces. Poor parents, let them be prepared for whatever the boy, instead of investing in his study. They must have had their good reasons. But this generates guilt, denial, free, all those negative things which Susan said. So that
Right.
is one thing which you can all think of. Maybe you can call some of us into your IPS meeting, Psychiatrist Association for communication skills or whatever. Not skills. It's just a
Humane touch.
humane thing. Yes, exactly. And then, so that is one thing. The other thing is what after me, of course, in a very humorous way, your friend Tilak put it this way, why after you? We are fine. Why do you ask why after you? It's a very important question. Why do you think, Mummy, we were worried after you? We are fine. We'll take care. So how do we drive that message? How do we drive that message? Because we have reached a stage where there are a lot of medicines, psychotropic medicines or anxiety. Quite a lot of work has been done. That is one thing. Is it possible to think of from the very first diagnosis? Again, I'm going back to the clinic psychiatrist consultations. One thing is this, apart from, sorry, I'm rambling across, but that's where something I forgot to tell. From the very first day, please emphasize on exercises, diet, as well as living alone.
Right.
Parents will be prepared, I'm telling you, because you know very well human beings are very resilient. Beyond that, we pick up our own lessons. Yes, you prepare your son, he can live, he can take his medicines. That is how the positive message is. So coming back to this, what after me? So we are very fortunate we are having Dr. Krishna Prasad here. My suggestion to Dr. Agalya and Krishna Prasad, now a facility like MPA, which are very good, highly reputed, well-known, it's a gold standard as far as, why don't you reach out? Why don't you spread out? Instead of residential, why don't you do assisted home care? Probably Dr. Krishna Prasad is the guru of assisted home care, the pioneering initiative in India based on our FACEMi model. Why can't halfway homes send out, instead of getting centralized building facilities for 20 or for 30 people, you will reach 200 or 300 people. And the Government of India in the Mental Health Care Act, Section 18.4B, has provided for supported accommodation, which, for the benefit of those who have not come across, I want to quickly say, the PMI, the person with mental illness, can get his own house certified if the person is not having caregivers around, or if the family ceases to provide care, like aging parents or family members who have to go to other cities, in such a brother and sister going away because of job. They're not, or even working parents, or those who are not able to give. Urbanization is a very different thing altogether these days, where the entire family is working. Who will take care of the PMI, the person with mental illness? Why don't we have institutions like MPA visit?
Maybe we should sit down and discuss this in some detail, Nirmala. We should do that sometime. We should sit down and discuss the practicality of this in some measure.
Yes. This is another suggestion. Instead of just having centralized facilities,
right?
You can reach out to more.
We'll definitely.
Yes. Sorry.
Try and work on it. No commitment, but certainly it's a thought worth considering.
It is worth thinking to cater to the needs of the current situation. It's very different.
Right.
So it's very different.
Thank you.
Thank you.
For those of you who don't know, this is a pioneering person in psychiatric rehabilitation from the family point of view. She started an organization called Amend, and she has now been at the helm. She's an Ashoka Fellow, and she's at the helm of rehabilitation, family-based rehabilitation for chronic mental illness. She has sublimated her own angst into a very wonderful atmosphere that we heard from Susan, how helpful it has been to have Nirmala around. And thank you, Nirmala, for your inputs today. We'll
Thanks
sit
a
down with
lot,
you sometime.
Thank you very much. Thank you.
Right. We've now slightly exceeded our time, but we'll still go on. If there are any more questions or remarks, I'd like to invite my teachers, Dr. Srinivas Murthy and Dr. Mohan Isaac, to say something. Professor Srinivas Murthy, sir, could we see you also? It would be useful if we can.
Yeah, thank you very much. I think it's been as I began in the morning, at the beginning of the session, sorry, I'm not very well dressed since I didn't think I was going to come on the camera. Anyway.
Thank you. Thank you for obliging us.
No. There are 2 or 3 things which I want to share with you. During the last 1 year, there has been a group called Mission, started by Amit Bakshi. You know, it has more than
Amrit Bakshi.
Amrit Bakshi, sorry. And he's a dear friend since I looked after his daughter about 40 years back when I was in NIMHANS. It has got 355 members as of today. And it has taught me more than what I learned in the last 50 years of psychiatry. Listening to, seeing every day there is about 10 to 15 postings. No? So there is a whole world which is very different from the clinical world. That came out in the today's discussion also. The second thing which I want to share is that we need to develop a way of providing hand-holding to persons with mental illness and caregivers. This is a very strong thing that comes to me. You might say, is there a model? I mean, though I'm not advocating it, the reverse diabetes group, I accidentally joined because I'm a diabetic. They seem to be doing it very well. Look at it, and I'll be very happy to talk about it, but I don't want to elaborate on that. The third thing is the issue is, even today, as of today morning, a Tamil Nadu minister called Prime Minister as mad person, mad thinking. The deviancy model is the model that everyone is perpetuating. We need to move away. I have some things, and if necessary, I'll be happy to talk about it. We need to move away to make not patients population. And today it is possible to do that. And that should be our mission, to take away the stigma. Otherwise, any amount of public education, it will not help. Today, the Tamil Nadu minister says in the television, calls Prime Minister mad person, mad thinking. How will you expect people with madness or mental illness to come forward? And lastly, the point which made about empathy, which by Srinivas, is very, very important. For example, there is a paper in JAMA today, in about a month back, showing that when you have chronic backache, the sheer fact the physician is empathetic decreases the amount of drug you use, decreases the amount of surgery done to you. You know, it's a fantastic paper. I can post it in the group. So I can talk about it. Yeah.
It diminishes the pain also.
Pain, of course, pain and quality of life. So what I'm trying to say is that is another editorial is there last week saying that we must teach hope as a skill for oncologists, people with so there is a whole lot of things happening. Since I have nothing else to do, so I follow all of these things. But I think we must move away from this highly clinical, cross-sectional care to continuous care, what I call it as 5 Cs: comprehensive, continuous, coordinated, compassion care. If that can be done, then I think we'll be in a good position. Thank you very much.
Thanks for being here, sir, and thank you for your very valuable inputs. I wish we could put it down on paper, and then when we bring out probably a commemorative volume, we'll have your inputs on that, sir.
I'll be very happy to do that. Thank you.
Professor Mohan Isaac, Dr. Mohan Isaac has been the spirit of MPA for many, many years. We were a little apprehensive when we heard that he may not join, but I'm so glad that he has joined in spite of another engagement that he had. Dr. Isaac.
Yeah, thank you. Thank you, Ajit. I think it has been a wonderful discussion on various aspects of schizophrenia as we know it. All the contributions, whatever I could hear, have been very useful. I would like to just, I endorse everything that Dr. Murthy said. We have worked together for a long time, so our views are in large section aspects of psychiatry very similar. We both worked in community psychiatry, Bellary, etc. I endorse everything that he has said. I just want to tell you just a couple of things. For me, this year is a very, very important year because it was in January of 1974, that is 50 years ago, that I decided to do psychiatry specialization and I joined NIMHANS in 1974. It's 50 years. In the last 50 years, as a trainee, as a junior resident, as a senior resident, at different levels of the faculty, as professor, head of the Department of Psychiatry, and now again as a consultant working at Fremantle Hospital, I do see people with the schizophrenia almost every day. In fact, currently I'm looking after a team called the 20 who have had a first episode of psychosis are referred to us for a follow-up. So, as Ajit referred to, and maybe other speakers referred to earlier, the concept, the understanding of schizophrenia has changed over the last 100+ years. It was thought to be a very debilitating disease, but today I work with young people. I know the trajectory of the illness can be changed by number of interventions if they are diagnosed early, etc., etc. Ajit, of course, referred to the different notions about what causes schizophrenia, the role of mothers, the role of genetics, etc. It is still changing, and we know that the prognosis, the kind of thing we can diagnose of schizophrenia. I do not now believe that even if somebody says, oh, your son has a problem similar to schizophrenia, or your daughter has a death sentence at all, because the trajectory, the prognosis, we have a lot of information that if appropriate things are done, it can change. What I would like to focus is one of the things that I have learned in the last 50 years is genuine caring makes a distinct difference to the person who suffers from psychosis that we call schizophrenia. Of course, there are the antipsychotic medications. Dr. Murthy referred to back pain from JAMA and be lesser if there is empathy on the part of the psychiatrist. I'm now not referring only to psychiatrists, the people who care for the person who has schizophrenia. Genuine care makes a distinct difference. Antipsychotic medications are important. Other psychosocial interventions are important, but the carer's role is extremely important. I thought this was just something which I had observed. I have seen it in different places, different settings, not only in NIMHANS, in other kinds of places. But the validation of what I had always believed came up a couple of years ago in a paper, in a perspective paper, written by somebody who is very famous in psychiatry. If you're a psychiatrist, you will know this person's name, Nancy Anderson. She's a biological psychiatrist. She's not a social psychiatrist. She is a, a researcher, scientist. She was for a number of years, more than 2 decades, I think, the editor of the American Journal of Psychiatry. When one of the most famous persons who lived his whole life with a diagnosis of schizophrenia is, many of you in the audience will know, a person by name John Nash. John Nash, on whose life the book, the beautiful Access, John Nash, the famous John Nash, who won Nobel Prize for Mathematics and Economics in '94. He suffered from all his life non-adherent to medications. He was in and out of asylums in the United States. He got married. His wife, Alicia, famously divorced him because she couldn't live with him. But then, seeing his plight in and out of hospitals, she got him, started caring for him. And then they lived together. A few years ago, I think 2018 or 17 or so, both John and Alicia were coming back from Europe landed in Boston and were driving home to their house in Boston. And they met with a car accident. Their son, John Nash Jr., who is also a PhD in mathematics, suffers from paranoid schizophrenia. That's a different story. But what I wanted to say was, after their death, Nancy Anderson wrote a perspective paper in the American Journal of Psychiatric titled A Beautiful Love Story. This was about the life of John and Alicia. And what Nancy Anderson says is, but for Alicia, there would neither have been recovery nor a Nobel Prize. Of course, John Nash never took medications. He famously recovered from the 90s. People in the university were used to wander around the garden as a madman to him, and he would solve the problem much better than, their own guys. So I have
I don't know. I think we lost Dr. Isaac. We'll wait for Mr. Samuel Mohan, our former secretary, had raised his hand, even as I announced that I wanted my teachers to speak. Mr. Samuel Mohan, are you there? Mr. Samuel Mohan, our former secretary of MPA.
Unmute. Can you hear me?
Yeah. Can we see you? Can we please see you? Samuel, Sam, can we see you, please?
Can you hear me?
We can hear you, but can we see you?
Okay. It's not okay. Fine. Thank you. This is not going, man. Can you? I don't know. The camera is not coming on.
Yeah, it's working. Fine.
Another thing, I'm driving actually. See, what my question was that this particular illness, the condition, is it totally curable? Number one. And we got success stories. Do you have success stories around the world? Secondly, thing is that what age group it is mostly, I mean, people get this illness. These are my questions. Because I got some relatives suffering at various ages.
Okay. Yeah. Krishna Prasad, would you like to take those up? Is it curable? And secondly, at what age is it likely to strike?
So usually it presents at least in males in their 20s. So usually it's the early or the mid 20s that it presents in males. In women, it presents slightly late, usually in the late 20s, and there is another peak in the 40s. So it's slightly different between both males and females. But having said that, I think it's also recognized that before the onset of the very clear psychotic symptoms, many people have a long prodrome that lasts from, say, weeks to months. And that again provides a possible opportunity to intervene. So this is at least what is known about the onset of the illness. And then you can extend it a little even before the prodrome to very early signs, very early indicators for the risk for developing schizophrenia. So as far as curability is concerned, I think cure is a panacea that we all look for in schizophrenia. So I think there is a category of patients who do completely remit, and there is a category of patients, at least roughly 30%, who would continue to have symptoms. And then there are people who are in between, and people can have episodic courses with complete remission in between. People can have with episodes without complete remission in between as well. So I think what matters, as everybody mentioned, is humane and compassionate approach and continuity of care. And I think our approaches now are changing from looking at recovery from symptoms to looking at achieving personal goals and looking at strengths rather than, though we are trained to look at deficits, I think more and more it's recognized that looking at strengths and looking at personal goals are more important probably than symptom remission.
One final question to you, Krishna Prasad, is thank you for answering Mr. Samuel Mohan's question. Sam, is that adequate for you? Sam, your question is answered? Sam, your question answered?
Yeah, answer one thing came to my mind, but didn't at a short of time. And is diabetic people with serious diabetic conditions are more prone to this schizophrenia?
People with diabetes more often experience common mental illnesses like depression or anxiety than severe mental illnesses like schizophrenia. On the contrary, people with severe mental illnesses, including schizophrenia, are at high risk of developing non-communicable diseases like diabetes, hypertension. So, at least in a recent study that a cross-sectional one that we did, which involved NIMHANS and other South Asian countries, at least 1 in 10 patients with the severe mental illness had diabetes. The problem is that more than 70% of the people did not know that they had diabetes. I think that's where the issue lies.
Okay.
Yes, sir. Thank you so much.
Krishna, what is the role of occupational therapy in improving the prognosis or quality of life?
I think vocation or work is a very important facet for recovery. In fact, I remember one of our fellowship students looking at what is important for quality of life for people with schizophrenia. Work came as the most important thing that people mentioned as important for quality of their quality of life. And I think people, at least in the West, a strong emphasis is placed on looking at supported employment services for people with mental illnesses. And when we say supported employment services, it has changed from looking at work as a stressful environment to say people being provided placement and then trained. So I think we have moved from train and place models where we believe that people with schizophrenia take a lot of time before adjusting at workplace, require a lot of training and reskilling before they're placed at work, to now looking at models where people are saying that people need to return to work soon, need to be skilled subsequently at their workplace and provided reasonable accommodation at workplace.
All right. Rohini, do you want to say something quickly? Because we're really
Sorry, just one question I had based on what Mr. Samuel Mohan was asking. Since Dr. Krishna, you said that, early onset, not early onset, regular onset for schizophrenia is 20 years for males and, late 20s for women. If when that age passes, I mean, can people breathe a sign of relief?
No. These are
if no symptoms are public.
We do.
Sorry, I just had to ask that question.
Of course, they are the risk periods, and it can occur across the lifespan. We do see people with very late onset.
Right. I'm aware of that, but protective factors.
We do see children also with very early onset schizophrenia.
Right.
Rohini's question reminds me of the lady who rang up the airlines and said, "What I read in the papers that is a 1 in a 20,000 chance of your plane carrying an explosive bomb. Do you call yourself a safe airline? Or what is this you're trying to do?" So he says it is a safe airline. 1 in 20,000 is a very slight chance, and not every bomb that is carried will cause an explosion. So the lady goes on and said, insisting that you're not a safe airline. He says, "Madam, please do one thing. I have a request to you. Please carry a bomb with you. If you carry a bomb with you, the chances of a plane having 2 bombs is about 1 in a million. So nothing is going to happen." So I don't think just because you pass that age, it's not going to happen. But that's really
the outliers are there, so I'm just trying.
Right. Anyway, you're
Thank you
past
so much.
the age of risk if you must look at your own logic. Concluding remarks, anything? Susan, would you like to say anything?
I think it's very important that the family understands this, realizes this, and gets out of this guilt thing, and partners the child or the spouse or the person who's affected. Family support is like the thing to do, because you have this love behind being strict and firm. To have medication, to go to your meet your psychologist and all that. And I also think that going to work, even if it is for 2-3 hours in a day, going out of home is like, it really helps. The other thing which has helped Johan is yoga. He does a lot of exercise. He does a lot of exercise, and he gets this. He says, okay, look, I'm getting into a mood. I'm going to do my exercise. So I think these things are there. And then if a family is looking at all this and saying that, these are factors that help, and we have to treat, I mean, I try my best to treat Johan as normal, because I have Tiara. If Tiara walks barefoot in the home, I'm like, yeah, that's okay. But as soon as I see Johan walking barefoot, I'm like, what is this? Why are you,
Right. But at that stage, you don't have eyes, you have microscopes.
Yeah. So, these are things that, then you tell yourself that don't do this, just don't do this. You have to be there for him for right through. I think that helps. That really helps. And Johan has been, I mean, and he is supporting me. Sometimes he tells me, aren't you pushing me a little harder? Things like that. So, it's a teamwork, and, family stop saying that, I am doing something for somebody. I'm just the carer. I am the carer. I am the mother. And it becomes part and parcel of one's life.
I think what you said earlier, your experience in St. John's, when they told you this is not Johan, this is the illness speaking. That was a very good metaphor to go by. I think that's something which people need to understand and internalize when they are looking after somebody with this kind of condition. Agalya, do you have any additional points that you'd like to make?
Yes, sir. Actually, see, as part of their negative symptoms, residents also have difficulty to focus on the day-to-day activities. So they will be engaged with their preoccupation with thoughts, and their positive symptoms will be outburst. So we mostly encourage them to focus on like self-care management, interpersonal and communication skill, then work skill. There are residents who are also going under few trainings like Ishania Foundation. We collaborate with other organizations and make them engaged in job trainings, all those things. And also few residents are voluntarily helping in MPA half-a-home management, like helping in grocery, weight checking, all those things. And few residents are also helping in office jobs, like attending calls and helping few data entry like that. So we keep them occupied in those things. And also as an organization, we have this yearly once observing the World Mental Health Day, this Bangalore Rehab Cricket League, to motivate them and to break the stigma. And also we have few programs like Olympiad to keep them occupied for at least 3-month period. So which includes like individual and intellectual and group games. So to keep them occupied and focused and to build self-confidence among them. So also as an organization, we wanted residents to focus on those areas, and also to make decision-making, life skills training, and psychoeducation on illness and treatment, family intervention and family meeting, and focusing on social support and emotional support and moral support as an organization.
Right. So a lot of what you said is covered in what we call occupational therapy. And I think that's a very important facet which Krishna also was talking about. That makes a big difference. And what Susan said also resonates with this, and that the person's confidence must be built up. He must have an adequate contact with the outside world. He must have a good self-esteem that he's doing something or she is doing something useful. That's very important. Krishna, any concluding additional remarks from your side?
Yes, sir. I cannot underemphasize the kind of advocacy and pressure points that organizations like FACEMi and caregiver organizations are doing. I can see that visibly, and the urgency with which Dr. Nirmala Srinivasan has been pressing for certain policy and program-related changes that the government needs to make. And I think probably a larger degree of support from other family caregivers would probably enhance the outcomes for our populace. And I think some of the important initiatives that she mentioned, providing care at doorsteps, I think that's the need of the hour. And I think an approach that is a case management kind of an approach probably improves outcome, and very closely related to the fact that what underlies this is a humane and compassionate care that underlies this. One last point that I wish to make is about not to ignore physical health issues in people with severe mental illness. And as she mentioned, I think very early I think physical health related issues should be discussed in the collaborative decision making that happens.
Thank you. I think all those are important points that we need to pay enough attention. The humane approach is what has been emphasized by various people. Unfortunately, Dr. Mohan Isaac, when he was talking about it, there was an interruption. But now we've come towards the end, and we are dealing largely with an illness that has genes and molecules underlying it, which should not belie the fact that a humane approach is very, very necessary. So well brought out in the John Nash's case, because his wife came back to him not out of pity, but because she discovered that she could not live without him and that she needed to be with him. And that made a huge difference in that life. But that's a paradigm for us to go by. We have very few people who are likely to go on to have the prestigious awards like the Nobel Prize. But even without that award over there, it makes a big difference to the person's life if we have a humane approach, much as the illness is biological. Schizophrenia remains a biological illness, as many illnesses are. It's not a purely psychosocial illness at all. We must emphasize that. And parenting is not the root cause. Bad parenting is not the root cause of it, is something we cannot overemphasize. I'd like to thank MPA, particularly Rohini, for giving me the chance to moderate these sessions. I'd like to thank all my panelists for their very active participation. Aarti Jagannath, who is on our who is with the MPA as a professor of rehab at of social work at NIMHANS, has been very keen to bring out a commemorative volume. I'm sure that we'll have people from here who will contribute to it. Thank you very much, Rohini, for giving me this chance to moderate and chair this session. Over to you.
Thank you so much, Dr. Bhide, and thank you for accepting this in the last minute. And I really thank all our panelists as well. In fact, I would like to bring to everyone's attention that this has been one of our longest sessions thus far, and you know, extremely useful and helpful. Really appreciate the participation as well as the questions, as well as you know, the excellent inputs we did procure from everyone. May I hand it over to Jeffrey for the final word of thanks. I have shared the email ID as well as the YouTube channel link on the chat box for anyone. This video will go back on YouTube in the next week for you to please share and do subscribe to our channel as well. Over to you, Jeffrey.
Thank you, ma'am, and good evening, everyone. So it's my honor to deliver the vote of thanks on this occasion of MPA's 25th lecture held in observance of World Schizophrenia Day. And first and foremost, I would like to extend our heartfelt gratitude to our esteemed panelists. First of all, Miss Susan Bhaktul, caregiver and parent member of FACEMi, then Dr. Krishna Prasad, then Professor and Head of Psychiatric Rehabilitation Service at NIMHANS, and our Senior Counsellor, Agalya. So your insights and experience have provided us with invaluable perspective on schizophrenia and the challenges faced by those living with schizophrenia and the caregivers as well. So a special thank you to Dr. Ajit Bhide, our Vice President, for moderating the session with such expertise and grace. Thank you, sir. And we would like to also express our sincere thanks to Micro Labs and their team for enabling this session, handling all the technical aspects and providing the Zoom platform. Your support has been instrumental in making this event possible. So I would like to extend my appreciation to the residents and their families and the staff of MPA. For your continuous support and the involvement are the pillars of our success. And I would like to also thank the live members, the working committee and the managing committee and all the well-wishers of MPA for their support and the commitment to our cause. And to all those who have attended today's session, thank you for your active participation. Your engagement has made this discussion more interactive and informative and helping to spread the awareness about schizophrenia. And special thank you to Ms. Rohini Rajiv, the MC for today and the chairperson of Academic Public Service and Publication. Thank you, ma'am. And once again, thank you to everyone who have contributed to making this event a success. So let us continue to work together to raise awareness and to support each other. So thank you, everyone.
Thank you, Jeffrey. Thank you, everybody. Have a wonderful weekend. Please take care. Thank you for all the new joinees. Lovely to see everyone. Take care. Bye.
Thanks.